students, and our faculty for today is Dr. Hirak Jyoti Mondal, and he would be conducting today's class of organ donation and transplant. He's a consultant in Department of Critical Care Medicine, in charge gastro and liver transplant ICU at NH Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. His area of interest are in liver transplant. Over to you, sir.
Very good evening and warm welcome to all the aspirants. What we're talking about, donors. So first we have to classify what are the different types of donors. So based on that, we have brain dead disease donor. This is the most common type of donors that we all know. In 80% of cases, we receive organs from these brain dead donors. The definition of brain dead, it varies from country to country. So like in the most of the countries where we follow the UK protocol or Asian countries, brain dead is equivalent to brainstem dead. I will discuss it later regarding what is brain dead, what is brainstem dead, and how we'll manage a patient of brain dead in our ICU who is a potential donor. So next is disease after cardiac death. This is another type of death where patient doesn't fulfill the criteria of brain death, but patient relatives, they are willing to donate organs after the death. Then what we do, we remove the circulatory respiratory support in a controlled environment, like in critical care unit or in operating room. Then one doctor who is not attached to that organ transplant team per se, who declares the patient dead, and immediately transplant organ procreation for transplant has been started in that case. So there are potential two types of donors: donation after brain death and donation after cardiac death. Now another type of donor is living donors, like in kidney transplant. We know we can donate a kidney, even we can donate liver, small bowel, pancreas, and lung. And the numbers of living donors are increasing day by day because there is always a shortage of after death donations. So these living transplants, they may be either genetically related to the recipient or may not be genetically related. But one criteria is that they must be emotionally related. Regarding this living donor, one burning issue is whether we are doing anything like it's like an industry, you know, in some part of this world, they are doing this living donor transplant is like an industry. So it's beyond our discussion. We will not discuss into that, but there are some debate about the scope of this living donor transplant who are unrelated. Now, going into details, what is brain death? You will be asked question in your EDIC exam regarding brain death and brainstem death and how to manage a patient, brain death patient in your ICUs. So it is a complete and irreversible cessation of brain activity, and evidence of irreversibility is required. Like there is no motor function, the GCS is E1, VT, and M1. There is no response, and then what we do apnea test and some ancillary tests to declare the patient brain dead. So there must be an factor that could be able to do this severe kind of damage that must be present, and there should be no response. And third one is apnea test should be positive. So regarding this, you may ask question about apnea test and different brainstem reflexes like corneal reflexes, and what is the nerve root value, you may be asked. So being intensivist, what is your role to treat a patient who is a potential organ donor? So you have to maintain the hemodynamic stability, you have to diagnose the neurological death, and you have to prepare the family. You have to take you have to counsel the family sometimes repeated times, because they are not most of the family members, they are not willing to donate organs so easily, because you know they are receiving some kind of news And on the other hand, you are asking them to give some consent for organ transplant. There is that's not so easy. Even you can take help of some other facilities and some emotional psychological support you may ask family member, they may ask. So there are some implementing policy and protocols for organ donation, and communication with other teams like transplant coordination, organ procurement team, family members, and other multidisciplinary teams. It's required in part of a intensivist. So there are some excellent guidelines regarding management of potential organ donors. I am not going details into all of those. Here is a reference of a guideline. It was published in Indian Journal of Critical Care Medicine 2007. It's an excellent guideline. If you get time, it's as advisable that you go through it. So next is pathophysiology. What is the pathophysiology of brainstem death? So what happens in brainstem death? There is a loss of vasomotor control initially, so leading to an hyperdynamic state. It may cause to cardiac arrhythmias, loss of respiratory function, and other events like loss of temperature regulation and hormonal imbalance. I will discuss in one by one. So severe trauma and stroke, they cause damage to the tissues, increasing ICP, decreasing cerebral perfusion pressure. Ultimately, there occurs a vicious cycle where ICP goes on and on, CPP goes down, and more damage to the brainstem, and ultimately herniation occurs. This herniation occurs to rostral to caudal path, that is from midbrain, pons, and lastly from medulla. So what is the initial responses? Initial response is hypertension and bradycardia. This phase is called Cushing reflex, that you all know. As the brainstem becomes more ischemic, the vagal cardiomotor nucleus becomes ischemic, causing unopposed sympathetic stimulation and leading to a, I was talking about unopposed sympathetic stimulation, which cause tachycardia, hypertension, and high blood level of catecholamines. So this is called autonomic storm or catecholamine surge. After this phase, there is a profound reduction of sympathetic outflow, and there is loss of autonomic tone, causing vasodilatation and hypotension. So, and there occurs damage to hypothalamus and pituitary, resulting in temperature and endocrine dysfunction. And there is interruption of hypothalamo-pituitary adrenal axis. So, at this period, circulation must be supported, and artificial respiration must be started. Okay. So, in short, what I have said, there is Cushing reflex. There is cytokine surge, may cause myocardial depression. There is some spinal cord ischemia causing hypotension. There is myocardial ischemia, and catecholamine storm may cause neurogenic pulmonary edema. And release of pro-inflammatory mediators may cause lung injury. And there is some kind of lung dysfunction like atelectasis aspiration. There is elevated renal tubular biomarkers. There is pituitary ischemia causing multiple endocrine problems. And hematological, there is plasminogen activator can cause DIC. This area that I have said in last 2 to 3 minutes is very important for your EDIC exam, because multiple questions might be asked in this topic. So I will discuss one by one. First, what are the points? One is hypothermia, hypotension, diabetes insipidus, DIC, cardiac arrhythmia, pulmonary edema. These are the points that you have to keep in your mind regarding management of a patient as a potential organ donor. And there is a rule of 100. Your systolic blood pressure should be kept more than 100. MAP usually kept more than 70. Urine output that we keep around 0.5 to 3 ml per kg per hour. Target should be more than 100. PO2 should be kept more than 100. Hemoglobin concentration should be more than 10 gram. And sugar should be more than 100. This is called rule of 100. This is a very handy thing because this rule of 100 often asked in EDIC exam, and it's very easy to remember. Now, one by one management that I have already discussed. First, systemic hypotension is very common. So, fluid displacement is the first thing of therapy. We'll start with isotonic crystalloids, and here occurs a cause of 𝒉𝒆𝒄𝒌. So we have to start vasopressin drug. We have to start vasopressin drugs, vasopressors like vasopressin, noradrenaline. Here, noradrenaline is a drug of choice because the best vasoactive drug is not known. There is no drug is the drug of choice. No drug is called the drug of choice, but noradrenaline is the preferred drug for management of this hypertension. And combination of dopamine and noradrenaline is usually given when myocardial depression is there and you want to start inotropes and chronotropic agents. Is there any question regarding that? Are you clear? Are we clear? Because I want to do discussion in a two-way fashion. So do you have any questions till now? Regarding that autonomic storm that I have already mentioned, there is a release, huge release of catecholamines, epinephrine and non-epinephrine, which causes tachycardia, elevated cardiac output, vasoconstriction, and hypertension. This is an extremely dangerous condition for the potential organs. So we have to control that tachycardia and hypertension. For that, we have to start short-acting beta blockers or sodium nitroprusside. One question is often asked, what is the drug of choice? So drug of choice is sodium nitroprusside and short-acting beta blockers like S-monol. It's often asked in our EDIC exam. So don't forget it. And we have to give anti-arrhythmic drugs to control arrhythmia related to cytokine storm. Bradycardia usually resistance to atropine. So, do you have any idea why this bradycardia is resistant to atropine? Anyone?
Because the sympathetic innervation to heart is lost. So.
Exactly, atropine is a vagolytic drug, and already it's lost. Vagal stimulation is already lost, so atropine will not work. Here, the drug of choice is isoprenaline. So always remember it. Isoprenaline is the drug of choice. Regarding fluid management, I've already said isotonic saline can be given, or you can give isotonic steroids like 𝒕𝒉𝒆𝒄𝒌, plasmolide. Usually the normal CVP and PPV we always monitor. Central venous pressure usually keep 8 to 12 millimeter of mercury. And when patient is not responding with the fluid therapy, then we start initially vasopressors and inotropic agents. 3.9% initially is not used in high doses because of hypertonic metabolic acidosis. This is quite known to all. Synthetic starch is not used because of chances of AKI and other coagulopathies. And blood products are clinically indicated to keep hemoglobin more than 10. It's needed. Regarding respiratory management, it's quite easy. Usually we do lung protective mechanical ventilation. We avoid hyperoxia. Again, we avoid basal atelectasis and all. So it's quite simple. Recurrent, frequent suctioning is needed, and regular airway toileting is needed because mucociliary clearance is lost in a patient who is brain dead, and this is also and bronchoscopy may be needed when we are thinking about lung transplant and all. So regarding lung transplant, I also want to add a point. Pulmonary edema should be avoided because during resuscitation we give lots of amounts of fluids that increases extravascular lung water, and when extravascular lung water is quite high, lung transplant actually patient is not suitable for donation of lung. So reduce atelectasis and avoidance of interstitial fluid overload. These are the two main things. Here is a one important topic, and questions may be asked. What is neurogenic pulmonary edema? These occurs because of high left-sided heart pressure, and there is a sudden onset of interstitial edema, and there may be some kind of alveolar hemorrhage. This is called neurogenic pulmonary edema associated with inflammatory damage and catecholamine surge in case of brain dead patient. So it's a differential diagnosis. Next, endocrine management. Endocrine management is very important. Thyroid hormone, corticosteroid, EDH, and combination therapy that we do. So what are the endocrinal changes that I've already described? Because there is damage of pituitary, so all the hormones get depleted, and there are all the changes. There is this is a wonderful slide showing each and everything what possibly can go wrong in a patient with potential organ donor. So hormonal resuscitation, regarding hormonal resuscitation, there is no level 1 or level 2 evidence to use hormonal resuscitation until the patient is not hemodynamic stable. So the thing is, when your patient is not responding to IV fluids, vasopressors, inotropes, then you can go for hormonal resuscitation. And what are the hormones that you have to give? You have to supplement thyroid hormones in view of oral T4 or IV T3. Then IV steroids, IV corticosteroids, methylprednisolone is a drug of choice, and the dose is 15 mg per kg. This is the absolute dose, and you have to remember this. And regarding other hormones, we give vasopressins. So next, infectious disease prevention that is needed, and prophylactic and antibiotics can be given, and sepsis bundles should be followed because these patients are at risk of increased infection. And another important thing is temperature management, because your hypothalamus is lost, so there is some kind of hypothermia. So external warming devices are required. Fluid usually that we transfuse are warm fluid, and we have to monitor temperature continuously, preferably the central temperatures. And regarding general care, don't forget the general care of a patient in your ICUs, like early feeding, and like propped up position, and eye care, and other first heartbeats. This you have to remember. So another important area where you can get question is diabetes insipidus. But the kind of diabetes insipidus in this kind of patient is central diabetes insipidus, where you are getting polyuria or hypernatremia. This slide shows what are the criteria for diabetes insipidus, and it is associated with the dyselectrolytemia that should be treated accordingly, and drug of choice is vasopressin, and this diabetes insipidus should be treated 50% with hypotonic saline or 5% dextrose. So you have to remember diabetes insipidus, and you will be asked question in your EDIC exam regarding diabetes insipidus. So there is one app, it's one of my favorite. It's available in UK and some countries. So if you go through this app, you won't miss anything regarding to optimization. So we have completed our first part, how to optimize our donor who is potential brain death and potential organ donor. So in these regards, you will be asked question like how to manage hemodynamic condition, what are the potential complications that we were expecting, what are the how will you manage dyselectrolytemia or hormonal dysfunctions, what is neurogenic pulmonary edema, and what are the drug of choices for hypertension, hypotension, etc. So any questions till now? You can ask me. Anyone?
What is the most complication that appears, sir?
What are the complications?
Yes.
Pardon?
Yes.
What are the complications of a patient who is brain dead? Are you asking that?
Yes, yes, sir. Yes, sir.
Okay. So I have already discussed. In brain dead patient, there is series of pathophysiological changes, starting from hemodynamic instability, hormonal dysregulation, there is dyselectrolytemia, kidney injuries, and everything. And you have to manage each and everything. So starting from beginning, you can see I have already mentioned what are the different pathophysiological changes that you understand. What we can do a close recap. So you will understand, and I will discuss the potential areas where high yield areas where you can get questions. That what are the pathophysiology, and what are the difference between cerebral perfusion pressure, intracranial pressure, and mean arterial pressure that can be asked, and what is Cushing reflex, what is catecholamine surge, that's a very important area, and damage to hypothalamus or pituitary and its implications, this is important, and how dysautonomia can do vasodilatation and hypotension in these patients. In these slides, we have mentioned how there is myocardial depression or Cushing reflex. What is Cushing reflex? What are the respiratory complications? What are the renal and endocrine and hematological complications? These are, in short, the complications that you are expecting, and you have to do. You have to do one by one. You have to go one by one. First hemodynamics, and then other organ supports. And the main areas that you have to cover. You have to prevent hypothermia, hypotension, diabetes insipidus, DIC, cardiac arrhythmia, and pulmonary edema, because these are the most frequent events that prevent us to preserve an organ for another patient. You know, this is very important. Are you clear?
Yes, sir. Clear, sir. So the most common
complication, if they ask you in EDIC, so what are the most common complication of a brain dead patient, and these are your answers. Hypotension, this is the most common cause that we lose a patient, and we lose multiple other. We not lose one life but multiple lives. Okay. So if I ask you questions, so what is the cause of hypothermia? What do you think? So because thalamic dysfunction, you know, hypothalamus is gone, so thalamic dysfunction, so there will be hypothermia. You have to prevent hypothermia. Hypotension, that sympathetic surge, everything is gone. So that I have already discussed, you know, that pons, midbrain pons and medulla is lost, rostral to caudal. So there will be profound hypotension, and you have to correct it. There's diabetes insipidus because of vasopressin, loss of vasopressin because pituitary is damaged. That DIC because of plasminogen activation, and cardiac arrhythmia can occur transiently because of catecholamine surge, and thus pulmonary edema is also for catecholamine surge. Okay, so are we clear?
Yes, sir. I'm clear, sir. Thank you, sir.
Okay, sure. After this, the potential area is rule of 100, and this management I have already described. So don't forget esmolol, don't forget sodium nitroprusside. And regarding fluid management, always answer like balance salt solution and interstitial fluid overload, neurogenic pulmonary edema. Endocrine management is very important. Current guidelines, I have already told you. Dose of steroid is very important. And infectious disease prevention, temperature management, and general management. These are important things. Okay. And lastly, the diabetes insipidus is a very important topic. So these are how will you manage a patient with brain dead patient. Now coming to our next topic, which is organ donation. So I have already discussed what are the types of organ donor. Then the question arises, the exclusion criteria for organ donation. This is a very important part where you can get questions in EDIC that what are the exclusion criteria for organ donation. Any active infection, active malignancy, the acute organ dysfunction, these are the exclusion criteria for organ donation. You have to go through by your books regarding this, because there is high probability you get questions. Okay. What are the accepted age? Again, I must say this varies from country to country. In general, this is the accepted age which is followed in European countries. So I have put this. Now another important thing, it's very interesting. What are the sequence of organ removal? So what they do? They do a midline laparotomy, and they always check that livers and kidney for because there is high chances of tumors. You have to maintain cardiovascular instability during that, and you have to prevent blood loss, hypothermia. First, they remove thoracic organs, heart and lung, and followed by abdominal organs like liver, pancreas, kidneys, and all. So, what are the organ? These are the usual time for organ prevention, preservation. That is heart, lung. The highest time is for kidney, it's 72 hours. So the next point is transplant. So transplant is a huge thing. It will take a long time, because we have to talk about each and every transplant: kidney transplant, liver transplant, lung transplant, intestine transplant, pancreas transplant, skin transplant, and everything. So this will take a lot of time. So I will discuss the frequently asked questions in transplant. So it can be divided into the various types of transplant and how we manage a patient of post-solid organ transplant with ICU with infections, and what are the core areas that you have to remember regarding a transplant, because it's a very specialized thing. As we do frequently liver transplant, what I can say, it will take me for another 2 to 3 hours if I want to teach you each and everything about liver transplant. So I have made these questions which are frequently asked in EDIC exam. So we will discuss this question one by one. So what are the contraindication of tissue donation? Anyone?
HIV infection, sir.
I have already put in previous slides what are the contraindication, like active malignancies, like active infections, sepsis, and high age. Sometimes 85 years age is an absolute contraindication. In some countries, around 80 age is an absolute contraindication. So you have to mark these things. These are the important type of questions. Now, next question is physiological changes in transplanted heart. So, do you have any idea what are the physiological changes in transplanted heart? So you have to read the heart transplant at least for once, and you will pick some of the salient points, like what are the common drugs you need, what are the common pathophysiological changes and all. So here I can say that in the most common question that you will be asked, what is the drug of choice to manage bradycardia in a transplanted heart? So what do you think? Which is the drug of choice to manage bradycardia in transplanted heart? Any idea?
Isoprenylin.
Yes. Isoprenylin. So what is the cause? What do you think?
So because of cardiac denervation, sympathetic that vagal is lost, autonomic innervation is lost. So,
Exactly. This is a very important question, sir. This often asked. It has been asked previously in EDIC exams. Because of cardiac denervation, you have to give isoprenylin, or you can give ephedrine. Isoprenylin is the drug of choice. Atropine will not work, and that the transplanted heart, it usually heart rate doesn't vary much. It remains around 90 to 100 in post-operative period, because there is no autonomic instability in transplanted heart. Again, there must be 2 POFs in a transplanted heart, because the native RA that can produce 1 POF, and the transplanted heart, it also produces another POFs. So these are the important things. Okay. And next, what are the different type of rejections? Do you have any idea what are the different type of rejections? In solid organ transplant, there are several kind of rejections. First is primary non-functioning. Primary non-functioning means when you have done graft transplant, and the graft is not functioning from the very beginning. You can determine that within minutes to hours that your graft is not functioning. Even it is possible for heart, kidney, liver, for every organs, that patient becomes hemodynamic unstable, and patient your lactate is high, and graft is non-functioning, and the mortality rate is almost 100% if you don't do any retransplant in this patient. So in primary non-functioning, it's the most devastating complication of a transplant. Then comes rejections. Rejections is acute rejection and chronic rejection. Chronic rejections, these happens over a prolonged period of time. These are often manageable, and we will not discuss about chronic rejections. What will we discuss? We'll discuss acute rejections. Acute rejections and hyperacute rejection, because these are the very important thing, and questions may be asked, and the role of intensivist is very important to prevent these rejections. So regarding rejection, what is hyperacute rejection? Hyperacute rejection is a thing when patient's antibody is working against that donor antigen. So there comes an hyperacute reaction, and the chances of rejection is very high in hyperacute rejection, and it's almost 100% if you not do in profound immunosuppression with IV corticosteroids, bolus therapy, or ATG, T-cell depleting agents in high doses. Otherwise, the chances of rejection and graft failure is very high in hyperacute rejection, and this can happen within minutes. In minutes to 7 days, hyperacute rejection. Yes? Yeah. Any questions? Next, after hyperacute rejection, there is acute rejection. Acute rejection can cause within first 7 to 5 months, and it may be both T-cell mediated cellular rejection or antibody mediated. The chances of graft failure is very high with antibody mediated rejection, and this is also treated with pulse steroid therapy and ATG. Sometimes plasmapheresis may be required in acute rejections, which is antibody mediated. So these are the terms that you have to keep remembered. And apart from rejections, what are the most common complications, surgical complications, and that you have to remember. What are the most common surgical complications in a post heart transplant, lung transplant, and liver transplant patient? Like hepatic artery thrombosis, focal vein thrombosis. What we do regularly to monitor the surgical functions, graft function, it's also important. And After that, coming to our next question, what are immunosuppressions and its complications? So immunosuppression is again a very important thing. You have to read immunosuppression in details. There are main 4 types of immunosuppressions. First is corticosteroid. Next is calcineurin inhibitors like tacrolimus or next is mTOR inhibitors. These are the newer immunosuppressants. And last is antimetabolites like mycophenolate all. In most of the patients, we manage with a combination therapy for corticosteroid and calcineurin inhibitors, that is CNI, that is tacrolimus, everolimus, or cyclosporine. And you have to monitor immunosuppression function based on their trough level or peak level. Like in case of cyclosporine, we see 2-hour peak level and trough level. Like in tacrolimus, we see the trough level. And regarding that complications of immunosuppressants used in different organ transplant is very important for your exam. Always keep that into your mind. So what are the most common complications of different immunosuppressants? Start one by one. First, start with corticosteroids. So what are the most common complications with corticosteroids? Anyone? So corticosteroid that cause stress ulcers, can cause osteoporosis, it may cause hypertension, hyperglycemia. You have to control blood sugar levels. These are very important. And next is CNI, tacrolimus. Tacrolimus, what are the complications of tacrolimus? Tacrolimus is a very important drug. CNI is a very important drug in transplant. So tacrolimus can cause renal injury. AKI can cause hypertension. So these are very important. One question, it was previously asked in EDIC, what is the drug of choice to manage hypertension in a patient with CNI-induced hypertension? Like in post-transplant patient who was on CNI, patient presented with hypertension, how will you manage? Which is the drug of choice? Any guess? Anyone? Please be interactive, otherwise these are very important questions, and questions might be asked. So in tacrolimus-induced hypertension, the drug of choice is calcium channel blocker, dihydropyridine calcium channel blockers, like amlodipine. Okay. Verapamil and these drugs is usually avoided because of constriction of the transplanted vessels. So calcium channel blocker is the drug of choice, and next is beta blockers.
Excuse me, sir.
Yes, any questions? You're most welcome.
How we differentiate the cause of hypertension? It's caused by tacrolimus, or maybe it's coexistence of this patient, sir?
Yes. I got your very good question. Excellent question actually, because some patients who are not previous hypertensive can develop hypertension post transplant, usually renal transplant or liver transplant. In this patient, we have to monitor the trough level of tacrolimus. Usually, if it is in therapeutic range, the chances of development of hypertension is quite high in this patient. First, what we do monitor the trough level. If it remains in therapeutic range, the chances is quite high, because tacrolimus is very notorious to develop hypertension, persistent hypertension, and calcium channel blocker is a drug of choice. Obviously, we have to rule out the other causes of hypertension that you were asking, that is pain and pain, anxiety, and all that we have to rule out, and we have to do Dopplers, whether there are any new renal artery stenosis and any stenosis is there or not. But in most of the cases, when patient is getting calcineurin channel inhibitors, the hypertension is because of that drug only. Okay.
Okay, thank you, sir.
Next is how will you monitor graft function in your ICU? So when we are talking about graft function, there are multiple grafts like kidney, liver, lung, like heart. So this question is mainly asked for liver and kidney. So for kidney, there are multiple markers, tubular, which are markers for tubular injury. And for liver, you have to monitor regularly the liver function tests, that AST and ALT level, that bilirubin level, because bilirubin it's a synthetic function. For synthetic function, you have to monitor PTINR and albumin level. Okay, for both synthetic hepatocellular injury and for excretory function, you have to monitor this. And apart from that, what you have to monitor? You have to monitor regularly with Dopplers, whether the all the vessels are patent or not, like hepatic artery, the portal vein, and common bile duct. These are patent or not. And patient is developing any lactic acidosis, any hypoglycemia or not, because these are the important markers when we can think about graft failure in the most of the patients. And next is what is warm and cold ischemia time. So what is ischemia time? Ischemia time when in a brain dead patient, you are taking the organ from that patient and preserving it in a cold solution. That time is called donor ischemia time, donor warm ischemia time. This time is quite low, less than 5 minutes. And after that, you are preserving that graft into the cold solution, and you are transporting that to the potential recipient. And when you are shifting that graft into the circulation of the recipient, this time is called cold ischemia time. And after putting it into the recipient and starting of reperfusion, this is called graft warm ischemia time. This is very important, graft warm ischemia time, because after when there is increasing ischemia time, the chances of graft dysfunction is always high. And during the reperfusion, if you have to maintain hemodynamics of the patient, because the chances of injury to the graft is remains maximum during the time of reperfusion. So keep into mind that when the patient, your graft is in a cold solution, the chances of injury is less rather than during reperfusion. So that's the important time. Next is time frame for different type of infection in solid organ transplant patient. You have to keep in your mind that in initial first 7 days, 1 to 7 days, the chances of local infection is most high. Like for liver intraabdominal infection, mediastinitis in case of lung or heart transplant, these are very high. And during hospital stay, the chances of MDR organism is very high. And what happens during first 1 to 6 months when the patient is getting and intensive therapy for immunosuppression, in that time, opportunistic infection in form of like CMV infection, like PCP, toxoplasma, like some nocardia or other aspergillus fungal infection is very high in this period. And after 6 to 12 months, it's like other community-acquired infection, like in other patients. So, question may be asked regarding the time frame of different time frame of infection, or what are different types of infection, what are different type of opportunistic infection, what is humoral immunity, and what is cellular immunity. These are important. Okay, like in listeria, the cellular immunity is important. Like for encapsulated organism, like Neisseria, pneumococcal, this for humoral immunity is very important. Next is calcineurin inhibitors. Like I have already mentioned, calcineurin inhibitors are very important. So go through it. What is cyclosporine, tacrolimus, everolimus? Go through it. What is its what is the mechanism of action? How it inhibits interleukin 1, 2, and TNF alpha, and what are the potential complications of calcineurin inhibitors. And next question is, what is treatment of acute rejections? So acute rejections, I think I have already made it clear to you, and acute rejections is mainly antibody mediated and cellular rejections, and we give pulse methylprednisolone. It's like 1 milligram per kg, around 15 to 20 mg per kg pulse methylprednisolone, and some ATG, anti-thymocyte globulin, that we use in high doses. And for humoral, for antibody mediated rejection, plasmapheresis, IVIG can be given. Okay. And PRES is another important entity in transplant patients. When usually happens with uncontrolled hypertension, patient comes with some like it's a mimicker of stroke. Sometimes patient presents with blindness or visual difficulty with headache, and it mimics like a stroke. And if you do MRI, you can get posterior circulation hyperintensity, equal intensity posterior circulation, and it is usually treated conservatively with BP control, and usually offending drugs it's stop. Usually calcineurin inhibitors are the culprits, and again it may happen with mTOR inhibitors also, and sometimes with mycophenolate, and we have to treat it conservatively. So regarding mycophenolate, that I was trying to say, that mycophenolate can cause mycophenolate induced diarrhea and profound pancytopenia. So you have to keep this in your mind, which immunosuppression can cause pancytopenia, which can cause hypotension, which causes renal failure and everything. Okay. So I think we have discussed the most of the important questions which are frequently asked in your EDIC exam, and we have discussed how to treat a patient with who is potential organ donor. So do you have any questions?
Sir, warm and cold ischemia, can you explain, sir?
Yes, warm and cold ischemia time. Warm ischemia time is for donor and for graft, and cold ischemia time is for the graft. Cold ischemia time it is when you have put your graft into the cold solution, and you are using your transport media and shifting that graft into donor's body, shifting the graft into recipient's body, and when and you are warming that graft, this is called cold ischemia time. So cold ischemia time is when you have put that into the solution, preservative solution. You have cooled it because it's a kind of ice bucket, and you are rewarming after shifting it to the recipients. This is called cold ischemia time. And most important time is graft warm ischemia time, because after rewarming, when you are starting reperfusion, this time, because you have your graft, it is rewarmed, it is inside recipient's body, but it's not getting any blood supply because you have not initiated that perfusion in that graft. So this time is very important. You have to do it very fast. You have to re-anastomose that into the recipient's circulatory system, and when patient, this graft is getting blood supply from recipient circulatory system, then it is called warm ischemia time, and it will start with reperfusion. So this reperfusion is very important, and warm ischemia time is very important. As you are taking more time to initiate recirculation, so warm ischemia time is getting prolonged, and chances of graft dysfunction is higher in that case. Okay, got my point?
Thank you, sir. Thank you.
So any other questions? Do you have any query? Because I might have missed some of the important topics, though I have tried to give you in a. I think I have discussed in a very simple manner. So if you have any confusion, please let me know. Otherwise, it will be, I mean, it will be a two-way communication, and I will be very, I mean, I'll be very happy if I help you any. So, any questions? Any further questions, or should we stop here? So, I think we should stop here today. And again, best of luck for your exam. So there will be multiple questions, and just go through these topics, what I have mentioned repeatedly, and I hope we will get questions from this. And best of luck. Okay, thank you everyone. Thank you.